In this chest X-ray, the frontal chest X-ray, one of the CP angle is very pointed, but the other one is not. There is a convex upward tendency which is seen. This is because of pleural effusion. So if the CP angle is not properly visualized with a concave meniscus which we can see, this will indicate pleural effusion. Now what is the minimum level where pleural effusion can be seen? In frontal chest X-ray, minimum 175 ml can be seen, which causes blunting of the lateral CP angle. In lateral chest X-ray, minimum 75 ml is required to cause blunting of the posterior CP angle. In lateral decubitus position, minimum 10 ml is required for blunting of the CP angle. Thorn sign. Thorn sign is fluid extending into the minor fissure, the lateral aspect representing the rose thorn. If you can see, the black arrow points to the pleural effusion, but the white arrow indicates that this fluid is extending into the minor fissure, only the lateral aspect, giving rise to thorn sign. How to differentiate pleural effusion versus ascites? Sometimes there is difficulty to differentiate between pleural effusion and ascites, especially on CT. So there are some signs. Let us study. First is the displaced crus sign. The crus of the diaphragm is usually attached to the vertebra. If there is pleural effusion, this crus will be displaced away, or there will be lateral displacement of the crus. As you can see in the diagram, the crus is being pushed away from the vertebra because of the fluid. The corresponding CT image, if you can see, the white arrow is pointing to the crus of the diaphragm, which is away from the vertebra, and below it is the fluid. So the second sign is the interface sign. In pleural effusion, the interface of the liver and the fluid is hazy, whereas in the ascites it will be well defined. As you can see in the CT image, the liver margin is very hazy, whereas in the ascites it is well defined. Third is the bare area sign. The bare area of the liver is usually attached to the ribs. If there is fluid, that means it cannot be ascites. Therefore, it has to be pleural effusion. See the image, the black arrow is pointing to the bare area of liver. Now the bare area in the other image is lifted up from the chest wall, and below it is the fluid. So this fluid has to be pleural effusion. The fourth is the diaphragm sign, which is the most reliable sign. If you can see the diaphragm outline and the fluid posterior and lateral to it, it is confirmatory that it is pleural effusion. These are all the signs which we have discussed. Now the next is the subpulmonate effusion. What do you mean by subpulmonate effusion? If the effusion is between the diaphragm and the undersurface of the lung, that is subpulmonate effusion. Now how will you see? If it is on right side, the laterally there will be displacement of the diaphragmatic peak, and if it is on left side, the distance between gas bubble and the lung base will be more than 2 cm. What is loculated pleural effusion? Also known as a phantom tumor, as it may mimic a lung lesion. seen in patient with congenital heart failure. How it is seen on CT? It is seen as increased opacity in the fissure with the beak or a slight opacity at a point with the fissure. This is a loculated fluid collection or loculated pleural effusion, also known as a phantom tumor. It is lamellar effusion. If the fluid is collected between the visceral pleura and the lung surface, it is a lamellar effusion seen in patient with congenital heart failure. Exudate versus transudate pleural effusion. Now, to differentiate is we use light criteria. What is light criteria of exudate? If pleural fluid protein divided by serum protein is more than 0.5, if pleural fluid LDH divided by serum LDH is greater than 0.6, if pleural fluid LDH is more than 2/3 of the upper limit of the normal serum LDH, this will indicate that the pleural effusion is of exudate cause. Now, what are the causes of transudate? Transudate causes are congenital heart failure, cirrhosis, renal failure, nephrotic syndrome, hypoalbuminemia, mixed edema. Remember, one more criteria of exudate is serum albumin to pleural fluid albumin gradient. If it is less than 1.2, it will confirm that it is. What is chylothorax? Chylothorax means pleural effusion which contains chyle. Now what is chyle? It is a high in protein and lipid, low in cholesterol, intestinal lymph which appears milky and it is carried by a thoracic duct. What are the causes? Lymphoma, thoracic surgery, MEDS, esophageal surgery, chest trauma, LAM, lymphangiomyomatosis, filariasis, central vein thrombosis, mediastinal fibrosis, and lymph nodes. How it will be seen on CT? It is seen as a near water attenuation, means the attenuation of water is around 0 HU. So around 0 HU, this will be seen, which can be either unilateral or bilateral. Since it is high in protein and lipid, therefore it will be hyper on T1. What is the treatment? If it is lymphoma, then radiation. If it is trauma, then it will resolve over time. Other causes, we have to do pleuroperitoneal shunt and have to ligate the thoracic. Now what is hemothorax? Hemothorax means blood in the pleural fluid. Now how will it appear? You know, blood has a HU of around 40 to 80, therefore greater than 50 HU will be present. If there is dense clot, then you can see some clotting will be present and fluid is going down, so there will be difference in the E level. So you will see a fluid level seen. What are the etiology? There will be trauma, or patient will have coagulopathies or rupture of aortic aneurysm, AV malformation, pleural endometriosis. Now what will be the complication? In chronic stage, what is pneumonic effusion? Pneumonic effusion means pleural effusion which is associated with pneumonia. There are 3 stages: exudative stage, fibropurulent stage, and organization stage. We'll study each in detail. Now the exudative stage means exudate is present. Now how it will be there? There will be increased permeability of visceral pleura because the patient is having pneumonia. So therefore exudate, small quantities, sterile and normal glucose will be present. And in X-ray the normal meniscus will be seen, and in CT crescent sign will be seen. It usually plus or minus will be associated with pleural thickness. What will you do? You will do a ICD drainage and put an antibiotic. Now the second stage is empyema, means it is getting infected. If it is getting infected, what will happen? It will no longer be sterile. Therefore, there will be either anaerobic or aerobic organism. Neutrophil will appear, glucose will decrease, increase LDH, organism will be seen. and this pleural effusion will start becoming localized, and because of this we can see split pleural signs. This will be non-dependent sharp demarcation, and in this the extrapleural fat thickening will be seen because there is more and more infection going on. The split pleural sign can be seen on CT. Here you can see the black and the white arrow is pointing to the pleura, which is hyperpleura, means the opaque white line on both the sides. Pleura is seen and between is the fluid. Therefore, fluid is split in the pleura and both side pleura can be visualized, which is the split pleura sign. What is a term known as empyema necessitans? This means that the empyema which we have discussed, it from the pleural wall, pleural effusion, it is going into the chest wall. So there is direct extension of the pleural fluid to the chest involved. This is known as empyema necessitans. Organism is TB mostly, or actinomyces or nocardia. Now what will you see? You will see the subcutaneous involvement because chest wall is involved, plus you will see the pleural fluid, extrapleural fat thickening and edema, what are all the features of the empyema, plus a subcutaneous involvement. As you can see in the diagram, the subcutaneous tissue, you can see that the last stage is organization, means the chronic stage. The empyema fibroblast will come and there will be fibrosis, there will be calcification, thickening and reduction in the size. Now we'll study pneumothorax. Pneumothorax means air in the pleural cavity. What are the causes? It can be either spontaneous or traumatic. Trauma history will be there, therefore traumatic. No history, then spontaneous. In spontaneous, it can be either primary, means no cause, or secondary due to any history of lung disease like empyema, alpha-1 antitrypsin associated with osteogenic sarcoma. If there is no cause, it is primary, seen in tall height, Marfan syndrome, family history, or idiopathic causes. In this chest X-ray, you can see one part of the lung is more black as compared to the other. There is a white line which is present, and medial to the white line, the lung tissue is present. This black line area represents pneumothorax. This white line represents the visceral pleura, and it is been pushing the lung medially. What will you see? As we have discussed, the frontal, it's a increased lucency, no vessels will be seen over there, visceral pleural line will be seen, and in severe cases tension pneumothorax. But in supine X-ray, there is one sign known as a deep sulcus sign. The CP angle in the involved area becomes abnormally large and lucent because of air which is present. Where it is present, you have to know the location, also it is very important. So this is the deep sulcus sign. As you can see in the diagram, the black arrow point is pointing to the CP angle, which is large, deep and more lucent, means more black as compared to the other side CP angle. This is the deep sulcus sign seen in pneumothorax in supine position. How to estimate the size of the pneumothorax? Pneumothorax is present. The upper, middle, and lower is labeled as A, B, and C respectively. Average it A plus B plus C and then divide it by 3. This will give you the estimate size of the pneumothorax.